Missed. Good morning, everyone. I'll be presenting my first thesis, that is Dr. Rajiv sir. That is development and validation of a risk. Yes. It is titled Development and Validation of a Risk Predictive Model for Varices Needing Treatment in Children and Adolescents with Cirrhotic Portal Hypertension. My supervisor is Rajiv sir, and Dr. Isha who's an AI professor, is also a supervisor. Coming to the introduction, as we all know, according to the Baveno 7 criteria, non-invasive markers are being used frequently, especially the use of platelet count and liver stiffness, as well as splenic stiffness, to rule in as well as rule out varices and decide the need of endoscopy in a significant proportion of patients. And varices needing treatment in children have prognostic and therapeutic implications, and the gold standard has been endoscopy for a long time, which is relatively invasive, and children need repeated sedation for the same, and there are some concerns of it affecting the neurodevelopmental outcome. Non-invasive predictors previously, as we will show, have inconsistent performance and limited validation. So the data is mostly heterogeneous, and these parameters that I have listed are used individually or in a combination in the form of indices for the prediction of varices needing treatment. And splenic stiffness is coming up as the latest marker for evaluation of the same. So coming to the rationale behind using liver stiffness and splenic stiffness and the comparison between them. So liver stiffness increases with fibrosis and indirectly reflects portal hypertension, whereas splenic stiffness is believed to be a more direct reflection of portal hypertension and can be used in cirrhotic as well as non-cirrhotic patient population. So coming to some previous literature. So these are the initial studies which showed the use of various indices which used these non-invasive parameters in a combination. So there are indices such as clinical prediction rule, APRI, which has been shown to correlate with varices needing treatment in a few studies, but mostly the correlation is more consistent with prediction of cirrhosis and fibrosis. Then there are other indices such as variceal prediction rule, which uses albumin and platelets, and a score which was developed at King's College, which is known as the King's Variceal Prediction Score. And the performance has been inconsistent across various patient cohorts. So this is a table which describes the biliary atresia cohort, where we can see that various factors, for example, in one study, the low platelet counts, low variceal prediction rule, and high APRI were seen to be good markers. Further, in other studies, history of failed Kasai, larger spleen size, lower platelet count, and higher APRI. Then there were recent studies which were using the adult Baveno 7 criteria and Baveno 6 criteria to see whether these criteria are useful in children as well. But the results are conflicting, and many studies showed that they had unacceptably high VNT missing rates in children, and they cannot be used directly. And there was another study recently which showed that a combination of echo parameters with bile acids can be used in children less than 3 years, and and splenic stiffness alone is a good marker in children who are more than 3 years old in a cohort of biliary atresia. Coming to other markers. So these are studies which are using liver stiffness with or without a combination of other non-invasive markers. So this was a study that used von Willebrand factor antigen and GP1B receptor along with platelet count and LSM or SSM, in which it showed that using SSM over LSM better improved the model prediction. Other studies showed that a combination of LSM and SSM were consistently performing better. And in one study, LSM could not differentiate between patients with or without varices or those who would present with a GI bleed. This is another study which is showing the summarizing the studies describing the splenic stiffness, which is done by various parameters, that is transient elastography or shear wave elastography, which are the most common parameters used in studies. In this study by Sutton et al., LSM was not a predictor of clinically significant varices, and only SSM predicted CSV in the whole cohort, which included non-cirrhotic patients as well. In this study by Kumar et al., the combination of other NITs was used, and SSM was a good parameter. In a recent study from our center, we found that SSM at a cutoff of 27.6 kilopascal predicted clinically significant varices in children. This cohort had a combination of chronic liver disease and non-cirrhotic children as well. And there is a recent meta-analysis in pediatric population on SSM combining 10 studies with over 600 children, which showed good pooled sensitivity and specificity for prediction of varices as well as clinically significant varices. So coming to the aim and objectives of our studies, our primary objective was to develop a prediction. Because the performance of these markers was okay. Yes, ma'am. What is FADA's meta-analysis? Ma'am, that is not assessing any other non-invasive markers. It is only studying the utility of splenic stiffness, and that is also done by various modalities. And in that study, they have shown that splenic stiffness alone has a good sensitivity and specificity, but there was heterogeneity of data and the methodology by which the splenic stiffness was done. Splenic stiffness is definitely one thing that does not have such a big gap. Yes, ma'am. So the primary objective was to develop a prediction model based on non-invasive parameters to identify varices needing treatment, then to validate this prediction model in another cohort of children, and to compare the model with other non-invasive indices of portal hypertension which are previously described, to validate the splenic stiffness cutoff value, which has previously been described from ours, from a study from our center, and to also develop and validate a machine learning model for the same. So it was a cross-sectional ambispective cohort. I have enrolled patients prospectively from August 2024 to May 2026, and the previous patients' data has been collected retrospectively. So all patients from 6 months to 18 years were enrolled with a diagnosis of cirrhotic portal hypertension, and this was my exclusion criteria. So endoscopic treatment for varices prior to presentation to us, vascular etiologies, and non-cirrhotic portal hypertension were excluded. So this was the data collection, the demographic record, the lab details, splenic size, which was calculated based on the ultrasound spleen size, and the score was derived as per the age and height centiles of the children. And liver and splenic stiffness transient elastography was done. This 3 months cutoff was taken for the previous patients. The new patients, the liver and splenic stiffness was done within 2 days of the endoscopy. Varices needing treatment was defined as per the ASLD criteria, and evidence of any other decompensation was also collected. So this was the study flow. Standard statistical analysis were done, and we analyzed the whole cohort, and we had a subset of patients in which splenic stiffness was available. So we did a separate subgroup analysis for them. So this was the baseline characteristics of the entire study population. A total of 645 patients in total were enrolled. This which was divided into a derivation and a validation cohort, that was 2/3 and 1/3. This was done using machine learning methodology for balancing the two cohorts. So as we can see, the median age was around 8.5 years, and 60% children were male, and the patients were predominantly compensated CLD. 40%, around 40% of them had ascites, and around 10% of them had hepatic encephalopathy. Ma'am, the previous in AC. Yes.
How did we exclusion criteria? This case cannot be clubbed because such patients, there is nothing like varices treatment. We should take a compensated group. Maybe early
Okay.
decompensated controlled ascites.
In the
Compensation is an extinction.
with up to grade 2 ascites, we have been able to do, but yes, ma'am.
How are the decompensated cirrhosis to go by splenic stiffness rather than endocrine? Then Rajesh, that's what I think you also want to answer that. How many, what is the proportion of varices in children with compensated versus decompensated cirrhotics? So because that data is also not there. Is that private data? That's a separate study. Yeah, means the grade 3 definitely, but that number is less. It is just 7 and 11%. So just hardly around 10% of grade 3 ascites. But in grade 2, we are able to do LSM as well as SSM. Show this your entire strategy. Yeah, don't put this set of questions. The exclusion criteria. There you should mention scientist grade 2 or 3. Only grade 1 is acceptable. Not 2 and 3.
Coming to the etiological distribution of our cohort comprised predominantly of biliary atresia, Wilson disease, autoimmune hepatitis, and the next frequent etiology was PFIC as well as PSC, which were well distributed among the derivation and the validation cohort. So these were the baseline characteristics of the population. As we can see, our population has a low serum albumin. Splenic Z scores were 3.3 Z score across the cohort. Liver stiffness, the median liver stiffness was around 35 in both the cohorts, and the median splenic stiffness was also around 35 in both the cohorts. The presence of esophageal varices was there in 82% of our patients, and high-risk esophageal varices around 38%. Varices needing treatment were present in around 1/3 of our total patient population. So the univariate analysis of the derivation cohort shows these parameters as significant. That includes clinical parameters such as decompensation, ascites, hepatic encephalopathy, low platelet counts, high splenic Z score, and LSM as well as SSM. So we did a multivariate analysis further, and the 4 parameters that were in the equation. So we have done specifically for that was also there, but it was not significant. Yes. So 27% total. Yes, sir.
Vis-a-vis the remaining cirrhosis.
This is for the whole cohort, sir. Yes, not we have done.
Yes. That's why we did the multivariate analysis in the whole cohort, and also she will show the subgroup analysis also later in individual 3 etiologies, the 3 commonest etiologies: biliary atresia, autoimmune hepatitis, and Wilson disease.
So for the whole cohort, the parameters in the equation were the presence of decompensation, low platelet counts, high splenic Z score, as well as high LSM. SSM was not taken in this equation, and it was present only for a subset of patients. So this equation that was derived from our whole cohort was then tested. The discrimination was good, and as the AUROC was acceptable with good, it matched well between the derivation as well as the validation cohort. We further did calibration and it showed strong agreement between the observed and predicted outcomes, which was checked by the Hosmer-Lemichaud test. So then coming to comparison with the other established indices, the score derived from our multivariable analysis performed better than the previously used scores such as the clinical prediction rule as well as the variceal prediction rule. And as we can see, APRI performed as well as chance and did not have a good discriminatory value. Now we are showing separately. Coming to the subgroup analysis, which was done etiology wise, these were the major etiologies which we had. So, from according to the three major etiologies, when we analyze Wilson disease separately, the increasing age as well as a higher splenic Z score, probably reflecting the underlying progressive portal hypertension, were the only parameters in the equation. When it came to autoimmune hepatitis, liver stiffness or splenic parameters were not in the equation, and only a low platelet count correlated with the presence of varices needing treatment. In the biliary atresia subgroup of 130 patients, female gender, presence of decompensation, low ALT and low GGT were the parameters in the equation. Yes, ma'am. Ma'am, Ma'am, I'm showing. No. Ma'am, we have not used splenic stiffness in this entire, in this, when we have done the analysis. Splenic stiffness we have done separately in the patients which we had.
The etiology should have come in the male analysis.
Hmm.
Because etiology is making a difference. And that is why you're going to subgroups of etiology. There again, the aim is to look at splenic stiffness.
Yes, ma'am.
So splenic stiffness is not.
No, but etiology, when we did the univariate as well as multivariate analysis, etiology did
Didn't
not
come.
come into picture when we did in the whole cohort. But in the subgroups of different etiologies, because apart from Wilson autoimmune and biliary atresia, there are other etiologies also. So, but when we did separate analysis for three different etiologies, so then
Etiologies. We should cover cirrhotic
Biliary.
in the male. Maybe you could have done biliary atresia and not.
yeah, it did not come. Yeah, it was not
There was
there.
no
So that we analyzed,
difference.
it was not.
Ma'am, in biliary atresia, female gender, presence of decompensation, low ALT and low GGT, possibly representing the decompensation stage itself. Varices needing treatment, sir. We see
So that also we see with
In-
advanced cirrhosis in biliary atresia, ALT, even GGT also decrease. So it comes out to around 60, 80, although at presentation when Kasai is
Yeah.
done, so the GGT values are 200, 300, but when they develop frank decompensation, the GGT levels also come down.
because most of the
Once the decompensation comes, there is no concept of varices needing treatment. VNT is needed with a compensated risk.
So that data is also not available for pediatric cohort. So that's what we want to assess, that with decompensation, what is the risk of varices in pediatric age group?
yes, ma'am.
Yeah, yes.
Hmm.
A separate set of patients with biliary atresia.
Yes, ma'am.
Because here.
Those who have already-
That's preceding other decompensations.
Ma'am, but okay.
All cholestatic
Hmm.
liver disease, varices first, then decompensation.
Cohort is 654.
Yes.
Yeah,
So this is the
she will
subgroup.
show for 284 patients for the whole cohort. She's
So
but instead of splenic stiffness for whole cohort, we have splenic Z score, which is almost equivalent, which we assume that it is almost
It is-
equivalent to splenic stiffness.
Within the department also that this study should not be performed for splenic, without splenic stiffness. But then, we had already done one study where it was proven, but Rajiv felt that we will get some new answers here.
But splenic Z score is available for all the patients.
yes, sir, yes. sir.
इसमें भी तो 284 ही लिखा है आपने.
ये सर with splenic stiffness है. In the previous In this analysis, it is available for all patients.
Study the parameter diagnostic attributes. So it has to be available in the entire form.
Yes, ma'am. So that's why we have not used splenic stiffness in the initial evaluation because it was not available, and we have done a separate analysis for the patients for which splenic stiffness was available. So coming,
Decompensation is a very valid point, sir, and Rakia pointing, but you should keep it in mind.
yes.
It help you in your.
Coming to the subgroup analysis, including splenic stiffness instead of splenic Z-score, which was available in 284 patients. In this, we see that the variables entered were all these, and the only two variables that came out to be significant were the presence of decompensation and a high splenic Z and a high splenic stiffness. And each
60.
Hmm.
68 is not.
Acha,
bold है मैम हाँ
Yeah,
Yeah,
2.9 and 1.096.
Here, if we compare, do you want to compare this with the previous study? So you can
So
tell
this is
here
the
that
previous cutoff that we had used in our previous study, and then in this study we have shown that it had a sensitivity of 95% and a specificity of 56% in the entire patient cohort.
What is your normal splenic stiffness? Children, what is
Hmm.
the norm?
There are matlab, less normal
First study
up
was
to-
published by Manoj and others that what is the normal splenic stiffness in adults before we started even. Study is published.
Oh.
32 Ankur has
the
done.
Ankur study has been published
Ankur-
recently, so that is in the normal. I think it is less than 15 something.
10,
It is
32.
30. So 32 is very high. 32 below 18. It should be below 18.
20.
Below 20.
Just no hypertension here in adults.
I think children should be less because हमारी study में तो 27 आया था.
28 and a half.
So here, what she actually, she did not mention, but she has written in the thesis, go back to the previous slide. Here specificity, if you see of the splenic
I've
stiffness is just
mentioned it later.
56%. But as per the meta-analysis and as per our previous study by Piyush, the sensitivity and specificity both were around 85%. So this is the actual specificity which is less. This is because on our cohort now, the biliary atresia are around 130 patients. In the previous study by Piyush, the biliary atresia comprised just 25% of the whole cohort.
So
So because she just missed that point, so that's why I wanted to clarify.
To drop out if you can't defend.
No,
No,
sir,
sir.
she already mentioned in the thesis, so that was.
So we see that a significant population, that especially the younger population with biliary atresia, tend to have enlarged spleens and higher splenic stiffness. So that limits the specificity of probably splenic stiffness in this cohort that has been described.
Stiffness without varices also.
Yes, ma'am. Even higher stiffness, even without varices. So this is not divided into validation. No, no. This is just the entire cohort has been analyzed.
Sample size कितना था और आपको कितना?
120 था उनका. So we further compared and used the Baveno 6-7 criteria in the whole cohort and saw how it performed in our patient population. So when a combination of low LSM and high platelet counts were used, we see that the varices needing treatment are only 3.3%. So it can be used to avoid endoscopies in children as well. And in this combination also, LSM of more than 15 and platelets less than 150, the presence of varices needing treatment was 42%. So it can be used to indicate the need for endoscopy. And the other the combination of LSM more than 15 or platelets less than 150 has a poorer prediction, but can be used to indicate need for endoscopy. But when we use the criteria of LSM, platelets, and the combination of SSM less than 40, there is a high miss rate of 15%. So this should probably not be used in the pediatric population. SSM less than 20, which is a good cutoff to rule out the presence of varices needing treatment. So it can be used alone, and SSM of more than 50, where the patient population 78% had varices needing treatment, can be used to indicate the need for endoscopy.
Sorry.
Hmm.
No,
I should ask.
no, no, so
This is to assess because the previous multiple studies had shown that the Baveno 6-7 criteria may not be validated in pediatric population, and the studies which are done were predominantly in the biliary atresia cohort. So this is a heterogeneous cohort, and we wanted to see whether the whether the adult cutoffs can be used in the pediatric population of cirrhotic children as well.
Time is getting over.
Okay, so we also did AI model development. So briefly, I will go that initially the optimal optimal parameters were selected, and according to the parameters selected, the AI model also showed a similar accuracy. So as we can see, the parameters in the AI model as well included LSM, presentation, that is with or without decompensation, low platelet counts, and splenic Z-score, which were the most important parameters. So the independent predictors of VNT were clinically the presence of decompensation, on lab evaluation the presence of a low platelet count, splenic Z-score on ultrasound, and liver stiffness. And the derived model had a good discrimination and calibration. In subgroup analysis, splenic stiffness showed strong predictive utility, and it outperformed other previous non-invasive tests. So it was a large pediatric cirrhotic cohort with internal validation cohort, inclusion of elastography parameters, LSM, which was available in all, and SSM in a subgroup, and etiology specific subgroup analysis is also available. It is the limitations being it is a single center study. SSM was available only in a subgroup of patients, and the low specificity that I have previously talked about may be due to enlarged spleen even without the presence of varices commonly seen in younger children, especially with biliary atresia. Yes, ma'am, predominantly. So this is the conclusion. Varices needing treatment were present in 1/3 of our population with cirrhotic portal hypertension, and a composite score may be helpful, but SSM needs to be validated in further pediatric cohorts, but seems to be the most promising marker for non-invasive prediction. Thank you.
Go back to previous. Yeah. No, go back previous. Yeah. Here SSM is nowhere.
So this has again been done without, because this is for the entire cohort. So we have not done for the
Go-
whole cohort.
Go back. Now here, no, go back. Where is your actual number of varices needing treatment? How many times were you right and how many you missed? All of them have endoscopy.
Yes, sir.
So I can't understand how many had, say you have,
So this 147 varices needing treatment.
so this is the calibration slide.
You let her explain. What is the number you missed?
So this,
I can't understand. You jumped everything. You have said the varices do not need treatment, but how many had varices which are high risk?
so total varices, high risk varices are these. High risk esophageal varices are these 38% and 38% and 42%. Gastric.
What did your model say? AI model, one line message.
So AI model had firstly identified the similar parameters that were identified by a multivariate analysis. And
This
this
is
was
not the way the presentation normally is, that you predicted so many do not. So how many you missed?
so
Or
this
how
can-
many you overdid?
Okay.
How many you overdid?
So this we can this was done by the patient. So this is for the derivation cohort. Separately, I will.
All the Baveno clearly says we
Mm.
predicted that 80% would have varices, but our model said 90%. So we overdiagnosed 10%. that they need. There is no clarity in my mind. What is the message?
That she showed in the table, go to the table, not from the model, but
In the
at
model,
least in the Babino table, we can again, this
Directly
table.
for our score
So
is
the-
not
ये
there.
तो Babino का
Yes, sir, this
definition
is,
है भाई.
so the same analysis we can derive for our model.
That we have not described in the thesis.
Anyway, this is not properly analyzed. I don't get any message. Sorry. What is the message of the thesis? What is the message? But this is as per endoscopy.
Yes,
How
sir.
many had varices and how many varices you picked up in your thesis?
So we have the accuracy that is
Right,
described at
endoscopy is the gold
70%, but we have
standard.
not.
So
Hmm.
how many had endoscopy VNT? Vis-a-vis how many predicted according to your model? What is the gap, plus minus? Where
That
is
we
that?
have not put, sir.
Any other comments?
Has to be for AI model, make it separately, splenic stiffness, you have a lot of good data. But do it properly, I think it's all jumbled up into one work, but it can be made into 3 separate papers, separate objectives.
This is always when Raji is going, yes, so much.
So everything here, like AI model, you develop because it will be the first in large cohort of patients. And use AI just to say clinically, whatever your varices needing treatment. For splenic stiffness, you have a smaller cohort, analyze it separately. So.
And
that
use
is-
it etiology specific.
The SSM prediction that you can see now, or maybe whatever you want to say, that can be done vis-a-vis huge paper, separately. Then you have a separate model that you can say, and then AI has also validated it that
You take out 3 more
3 हो गए ना,
separate.
और मैं समझती बिलियन ट्री से मुझे खुद ने बात निकाली, that is also very important.
The
Thank
new
you.
Baveno 8 guidelines in pediatrics are also available. Have you got them? Baveno 8 pediatric session has complete new guidelines. So that also you can use.
Thank you, sir.
I have a question. So what was the frequency of your probe?
100 hertz, sir.
That is fine.
Yes.
Good morning, everyone. My first thesis topic is transcranial Doppler for the diagnosis, monitoring, and outcome of raised intracranial pressure in pediatric acute liver failure. I am Aditya from the Department of Pediatric Hepatology under the supervision of Dr. Bikrant Bihari Lal sir. As we all know that raised ICP carries a very high mortality in children with liver failure. So an early detection of raised ICP monitoring and treatment is utmost important. So available monitoring, available diagnostic monitors include invasive as well as the non-invasive. Invasive being using with the help of extraventricular drainage and the interparenchymal monitors. Non-invasive techniques identify raised ICP on the basis of cerebral edema. They detect altered cerebral blood flow or they detect altered cerebral metabolic rate. The modalities that detect cerebral edema include like automated pupillometry, optic nerve sheath diameter, tympanic membrane displacement, ICP waveforms, and neuroimaging. Modalities that detect altered cerebral blood flow include transcranial Doppler, and thus modalities that detect altered cerebral metabolic rate include jugular venous, reverse jugular venous saturation, NIRS, and continuous EEG. So among these many modalities, most commonly used are the ONSD and the transcranial Doppler. The pros of using an ONSD is it is a simple bedside tool which shows the dynamic changes within minutes of change in ICP and can be easily trained to an operator, and it can be easily repeatable and economical. Similarly, transcranial Doppler is also a good bedside dynamic tool to assess the auto regulation, and continuous monitoring is also feasible. However, the cons behind ONSD and TCD being that is an operator dependent and expertise is required, and it is quite difficult to do in combative or in uncooperative patients. And in ONSD, there can be some anatomical confounders at the optic at the level of the orbit. In case of TCD, uh, uh, the TCD velocities can be affected by some physiological confounders like the CO2, temperature, and the blood pressure as well. So I'll go on with some evidence in the ONSD evidence in ALF. There are few pediatric studies. One was published from our center in 2021, which show that an ONSD more than 4.5 mm at baseline predicts 100% predict raise ICP, and a persistent of ONSD more than 4.6 mm at 24 hours despite management carries a poor prognosis. And responders have showed a greater reduction in ONSD after anti-ICP measures after 24 hours compared to the non-responders. Similar data has been obtained from a study by Das et al. From SGPGI, and a small adult study has also been reported. So the second modality for measuring raise ICP was transcranial Doppler. The principle include that it is an sonography, so it sends sound signals, and preferably we use a handheld probe at the temporal window to detect the changes in the cerebral, the velocity in the cerebral vessel. The most common vessel used is the middle cerebral artery, and we usually take an insonation depth of nearly 45 to 55 mm, which detects the M1 segment of the MCA. So what happens in the normal physiological conditions? The heart pumps the blood, which is reflected as in the waveform as a systolic wave, and during the diastole also it pumps the blood, which is reflected as a end diastolic velocity. However, in case of raise ICP, there is increase in the systole because of increased pressures, and during the diastolic form, there is a decrease in the end diastolic velocities because of elevated ICPs. So this is the waveform that we obtain in case of raise ICP, a sharp systolic weight and a nearly absent or a lower end diastolic velocity. So transcranial Doppler helps us assess other many parameters, like what we assess are the peak systolic velocities, diastolic velocities, and mean flow velocities. And there are also some derived parameters which we can derive from the absolute parameters, like the pulsatility index, the resistive index, the SD ratio. And also an important parameter is the estimated cerebral perfusion pressure and estimated ICP TCD, which we can derive from this equation, which was shown in a study by Zoinska in 1998 and later validated by Rajaji in 2018 in adult ALF. So what is the evidence of TCD in ALF? So there are some few case series which have shown the prognostic use of TCD in ALF, and most of the studies have shown that a higher pulsatility index have shown a poor prognosis in those patients with acute liver failure. An important study by Rajaji et al. Has shown that the estimated ICP from that equation, it closely correlate with the invasive ICP as they included patients who had invasive monitoring as well as who had non-invasive monitoring, and it closely correlate with an AUC of 0.9 to detect pressures more than 20 millimeter of mercury. On a recent pediatric study, it was published from King's, which has shown, which was a retrospective data over the last 10 years that showed that non-survivors children had a significantly lower mean flow velocity in the MCA, as well as a higher pulsatility index. And it showed, the PI showed a weak positive correlation with ammonia, while MFP showed a negative correlation with ammonia. So the lacunae right now is there is a very limited pediatric evidence of TCD in pediatric acute liver failure. There is a lack of serial longitudinal neuromonitoring throughout the disease course. There is limited evidence for the prognostic stratification, and there are limited data on the dynamic treatment response in raised ICP. So the aim and objectives. The aim was to evaluate the utility of transcranial Doppler for the diagnosis, monitoring, and prediction of outcome of raised ICP in pediatric acute liver failure. The primary objective was to determine the prognostic accuracy of TCD parameter of the middle cerebral artery, that is PI and ICP TCD, to predict the natal liver survival in PALF.
Transcranial Doppler.
So raised intracranial pressure, objectively, we have defined as a ONSD more than 4.6 mm from a prior base. Yes, sir. Yes, sir. So in the secondary objective, I have mentioned that to to compare the TCT parameters in PAL with or without RAISE ICP. And RAISE ICP we have objectively defined as an ONSD more than 4.6 mm from our previous study.
Gold standard is invasive ICP content because the gold standard cannot be compared with, that's why we have kept it in the secondary objective, this defined definition of ICP, one based on clinical and two based on ONSD more than 4.6, which comes from the PTV test. Your type, your objective is prognostic accuracy.
Yes,
That is a accuracy compared to what? That is mortality versus survival. So there is no nothing to compare with another model in that. That's why that is strict to primary objective. And comparison to another modality has come to secondary objective because the gold standard cannot be applied.
Not use it for standard gold standard. This cannot be the primary objective. You cannot say ONSD is the gold standard.
That's what I'm.
No, ma'am.
ONSD has shifted to secondary objective. Primary objective is prognostic accuracy.
Primary objective होना चाहिए outcomes means transcranial Doppler and brain outcomes.
That's why we had compare, ma'am, in the survival as well as.
Yeah, I'm trying to say that we cannot write diagnosis and monitoring. We can only say prediction of outcome.
That is what is written on primary objective. Prognostic accuracy.
So I would write over your neurological outcomes because I'm looking at transcranial Doppler and I'm looking at clinical salvage. Then I compare with other modalities in the secondary objectives. So to show whether one is better than the other.
For that point, the neurological outcome is very different because once the patient dies, you can never say that the patient could have woken up, would have neurologically recovered or not. That's why death and native liver survival were kept as two outcomes and
Two groups that we compared.
Patient who cannot bear to grade 4 whatever encephalopathy, which we can clinically objectively see. I would define it like that, but I may be wrong. I'm just suggesting. When you put it like this, you have to have a ICP policy.
Yes, sir. Other secondary objectives were to compare the TCT parameters in PAL with various grades of hepatic encephalopathy, to determine the TCT parameters at clinical ICP spike and 2 hours after the use of anti-ICP agents, and to correlate TCT parameters with time to successful extubation. So this was the study design. It was a prospective observation study, included all PAL from 3 to 18 years of age and excluded patients who were uncooperative and in which the TCT window we were not able to establish. And the serial neuromonitoring was performed at almost 9 time points from 0 to 96 hours. The absolute as well as the derived TCT variables were noted. And additional, we performed additional neuromonitoring during the clinical ICP spike and 2 hours after the use of anti-ICP measures. And also the simultaneous recording of the map, CO2 and temperature was taken at each time point. And the outcome was assessed at day 21 in terms of native liver survival, liver transplant or death, whichever came earlier. So this was the methodology used. The TCT examination was performed with an automated Doppler machine, which was Biosonic. The middle survey RT was just using a 1.6 megahertz probe through the transtemporal window, and insolation depth was kept as a standard 45 to 55 mm. And we measured all the absolute parameters, and we derived derived parameters like the cerebral perfusion pressure and the ICP TCT. And ONSD was performed as per the institutional protocol. We used 6.5 megahertz probe and measured at 3 millimeter behind the globe. So we included all the PALF admitted to the department during the study period, fulfilling the inclusion criteria, and an appropriate statistical method was used for the analysis. So coming to the results, so there were total 99 pediatric patients who presented to us during a period of 24 months, and out of which 29 were excluded, majorly because they were uncooperative, and in which TCT the window was we were not able to establish a proper window.
Inter-observer variable.
So it was done by a single observer. I have only done.
Observer variable.
We have not assessed. Yes, sir. Observer validity.
40% variable. Haven't added your stats, kappa stats.
We have not added, sir, observer variability. So.
Also ask, what is the expertise of the, like you are doing? What is your expertise of doing this?
It's an automated machine, so the expertise has to be with people who are working in the ICU, not necessarily for a radiology.
When we are saying studies, so we should say like inter-observer and intra-observer. So when we say inter-observer, at least one person and the other person.
Basically, it is an automated machine, so.
See, हमारे यहाँ it is being used for before him also it was being used for almost 1.5 to 2 years. So there was some background before we started this study.
Please let the student justify.
We should do an inter-observer. Yes, sir.
Everybody's using.
We did and total 70 patients were included in our study. Serial monitoring was done till 96 hours. Additional neuromonitoring was performed in 37 patients who had clinical ICP spike. And then a reading was also taken 2 hours after the use of ICP lowering therapy. And the patient was followed up till day 21 or LT or death, whichever came earlier. There was 40% natal liver survival. 15 children underwent liver transplant. It was 21%, and almost 40% succumbed. This was the baseline parameters. The median age was 11.7 years, almost equal male and female predisposition. At baseline, they almost 57% presented with advanced HE, that is grade 3 and grade 4 HE, and the etiology predominantly was hepatitis A, that was in 77% of the patients. Almost 87% required ICU admission and 70% required mechanical ventilation. This was fulfilling the first secondary objective. We correlated between the ONSD and TCD parameters at baseline and at a time of ICP spike. And we saw that among the TCD parameters, PSV at baseline and PSV at the ICP spike, they did not correlated with ONSD. However, other parameters like the PI, ICP, TCD, and end diastolic velocities correlated with ONSD. So PI and ICP TCD showed a positive significant correlation. However, an end diastolic velocity showed a negative significant correlation with ONSD. So both ONSD and TCD are complementary bedside neuromonitoring tools. So it's modest 0.46. Yes, ma'am. Yes, ma'am. But they're modest, but they're not, but they are significant. So that's fine. Because of the
But for correlation, I have a point that even if the value may be 0.4 or 0.5 for the R value, the P value is significant because it may be just a 30-degree line or a 20-degree line. But if the values are around that line, so that indicates very good
It has
correlation.
become open for all. He has his thesis presentation. Let him justify.
yes, sir. So they're showing modest significant correlation. Significant correlation.
Not defending, I think just putting word across.
So even centers who just have an ONSD facility or a
So you tell us what comes out of this slide. What is
So-
the take home from?
as both are complementary, so any center having just an ONSD or just an TCD, both any of the modalities can be used for non-invasive measurement of ICP.
Whichever expertise you have, whichever instrument you have, you should have at least one of these modalities at a center which can
Yes.
Next.
The next objective was to compare TCD parameters in parallel with or without raised ICP. We have taken an ONSD more than 4.6 mm to label it as a raised ICP, and we found that among the TCD parameters, end diastolic velocities, PI and ICP TCD was significantly PI and ICP TCD was significantly elevated in patients with raised ICP, and EDV was significantly lower in patients who had elevated ICP. So as the ICP has increased, it leads to an early reduction in diastolic flow. However, the systolic flow velocities are relatively preserved. Yes, ma'am.
Did not meet the criteria for your based on ONSD,
Yes, ma'am.
but still had worse outcomes. Based on your TCD,
Yes, ma'am.
what was the discordant that table?
Ma'am, we are taking yes, ma'am.
But the patient did not have ONSD above 4.
Ma'am, as such, there are no recommended criteria in. We were taking objectively ONSD as a parameter to.
Sanjana, what is she saying?
Yes, ma'am. But we do not have a standard TCD value where we can compare our data.
But for ONST at baseline was not suggesting that the patient had worsened.
Yes, ma'am.
You understood?
Yes, ma'am. But in our study, we have seen that almost ONSD and TCD both correlated well.
Is where it was, I was saying it is significant, but the correlation
Yes,
is
ma'am.
weak.
The next objective was to compare baseline ONSD and TCD parameters in patients with advanced HE and those without. We found that patient who had advanced HE had an elevated ONSD, significantly elevated ONSD compared to who have an HE grade 0 to 2. They have a lower industrial velocity and elevated derived parameters of TCD like PI, SD ratio, I, and ICP TCD.
What is the effect of ventilation? In 0 to 2, they were non-ventilated.
Yes, sir. So,
3 to 4, they are ventilated.
sir, even the ventilation, I have mentioned the physiological confounders like the CO2, temperature, and MAP. So the child who are on ventilator, the normocapnia we maintain in the ICU setups. However, the patients who are, and that CO2 affects the systolic velocities as well.
Ventilated
Yes, sir.
versus non-ventilated. If you have the same patient
Hmm.
who was non-ventilated, what was the TCD? Post-ventilation, what is the TCD?
So there were only, there was 9
Try
patients.
to calculate
Yes, sir.
that, it
So,
will help you.
We have done in the thesis part, I have not entered over here. There were 9 patients who presented with HE 0 to 2, and they progressively worsened, and then they were ventilated. So,
Effect of
yes,
anesthesia
yes, sir.
and ventilation on TCD, how is it making a difference?
Just theoretically, what will happen if a patient is ventilated? What will happen to his TCD parameter? Irrespective, suppose ICP remains same, then what will happen? That is the question.
So,
If like ICP बढ़ जाएगा, तो बढ़ जाएगा सब कुछ. But if ICP remains same and the patient is ventilated and the patient is not ventilated, what will be difference in TCD?
sir, in ventilation, we maintain a proper atmosphere, a calm environment where the pressures will not gradually increase. However,
The
It
temperature,
depends on PSCO2 and
yes, yes, sir. Yes, sir.
If the autoregulation is not intact, if the autoregulation is intact, CO2 will not make any difference in the flow.
Hmm.
But when the autoregulation is lost, CO2 increase will increase the flow,
Yes.
which means that if the patient is in grade 3 or 4 encephalopathy, we expect autoregulation is lost. And in this scenario, if the CO2 is increased, the flow velocity will increase.
Yes.
So these two groups are slightly apple versus oranges, because here you have the HE grade 3, 4, which has lost autoregulation, and grade 0 to 2 will probably have
Yes, sir.
preserved
Yes,
autoregulation.
sir. That's what, sir, we have also seen in some parameters, like if we see the PI, the upper quartile, see it is elevated in patients who were not advanced HE, and even the PI as well as the ICP-DC was elevated in those patients. So they subsequently they required ventilation, sir, because of improper autoregulation.
But this comparison, because in two groups, in one group, the autoregulation is supposedly intact, and in other it is not. So the comparison is not correct,
Not
in
correct.
my view.
This comparison is not correct. What is the
Ah.
what is the point to take from this side? Tell us the clear point.
you should only
No.
look into survival, not compare. I also totally, this was the reason. The grade 0 to 2 is different. They're not ventilated.
Yes, sir.
Here they are ventilated and the auto-regulation is gone. So don't compare. Anyway, go ahead.
Point यहाँ क्या है वो बता दो.
That's what I was telling, sir, that even the patients who had grade 0 to 2 encephalopathy, they
One quarter.
and
More and ONSD more than 4.6 and the TCD PI more than 1.
more than 1.2 and an elevation.
Suggestive of raised ICP, that means around 25% of patients with grade 2 HE will also have intracranial raised ICP.
Yes, sir.
Point is well taken, but don't put at least 0 and 1. If we are saying cerebral edema is there in 0 and 1,
Zero पे था नहीं, zero लिखा है.
so but this is something 2 we can accept, but 0 and 1.
5 दिन अभी है.
Yes, ma'am, we have included such because
So if
Okay,
it's
your time
grade
is
0 is
getting
having
over.
cerebral edema.
so The primary objective was to determine the prognostic accuracy of the serial ONSD and TCD parameters. So this is an extensive slide where we compared the serial ONSD and TCD parameters at different time points in between the patient, in between two outcome groups. First outcome group was survival, and other outcome group was death group. We have excluded the patient who underwent liver transplant. So what we can see from here that the patients who didn't survive had an elevated ONSD from baseline, and this the difference between the survivor and the non-survivor groups increased subsequently over the subsequent hours. Among the TCD parameters, PSP showed no significant difference between the both outcome groups. However, end diastolic velocity and mean flow velocity showed a significantly reduced velocities in the non-survivor group compared to the survivor group. And these differences have shown, later on I will show that the differences have shown gradual increasing after 40 to 72 hours. Among the derived parameters like PI and ICP-TCD, both the modality, both the parameters have shown an elevated picture in non-survivors compared to the survivors group, and all these parameters have increased subsequently after 40 to 72 hours. What I show in the table, I have showing in the whisker box and whisker plot, where we can see that the green one is the survivor and the orange one are the non-survivors. So with time, ONSD, the survivors have a slightly improving ONSD. However, among the TCD parameters like end diastolic velocity, the survivors have shown a gradual improvement in the EDV, a gradual.
Your SD is bigger than the mean.
So actually, yes.
You have to
Yes,
use
so-
median.
And improvement in the PI parameters and an improvement in the derived ICP-TCD. And these differences are more, the divergence we can see after 40 to 72 hours in all these parameters. So also we did a linear mixed effect model, and we found that the significant differences was, were observed according to the survivor status. Means those who survived and
Time is over.
yes.
Quickly
So
run.
I'll go on.
You can clearly make out the difference
Yes, sir.
between non-survivors and survivors. Before that, there is a lot of overlap.
Yes, sir. We did an ROC analysis to and also to determine the optimal cutoff of ONSD and TCD derived parameters for mortality prediction. We did an ROC curve at baseline 24, 48, and 72 hours. Yes, sir. Okay. We also determined the influence of physiological variables on TCD parameters. We did a multivariable linear regression and we found that the absolute parameters like the PSV, EDV, and MFP, they were affected by temperature. They were positively correlated and significantly associated. However, the derived parameters like PI and ICP-DC, they were not affected by temperature as well as PCO2. And this was the second objective. We checked the dynamic changes in ONSD and TCD during clinical ICP spike and following the ICP lowering therapy. They were total 37. Yeah, there were total 37 patients, out of which 56 had ICP spikes, and we used propofol initially, and then later on in refractory ICP we used thiopentone. So the patient who had ICP spike, clinical ICP spike, have done higher ICP-TCD and higher PI value. We also compared the change, the delta.
At the time, clinical rate IC spike, you can see that the PI has gone very high to 1.5. Calculate
And-
ICP by TCD has gone very high up to 35.82. And you can say that within 2 hours of appropriate anti-ICP therapy, the PI comes back to 1.16 and ICP calculated by TCD comes down to 14.68. That means ONSD as well as TCD are very good dynamic parameters to assess the response to
ICP lowering agents.
therapy. And
We also checked the delta change in ONSD and TCD parameter with ICP measures and compared that with the survival. Those who survived had a significant reduction in the ONSD, significant reduction in the PI and ICP-TCD and an increment in the end diastolic velocity. And this is an example of a patient where we did TCD at the ICP spike, where we can see an lower end diastolic velocities and higher PI value. And after 2 hours, we show
Give you a summary.
Yep, so, I'll go ahead. So, serial ONSD and TCD provides complementary non-invasive bedside neuromonitoring in children with PALF. Elevated PI and elevated ICP-TCD along with reduced EDB demonstrated highest prognostic accuracy for mortality, especially at 48 to 72 hours. And persistent PI more than 1, ICP-TCD more than 13.2 and ONSD more than 4.5 at 72 hours identify children at high risk of mortality. And PI and ICP-TCD were largely unaffected by physiological variables like the MAP, PCO2 and temperature, body temperature, supporting their reliability as a bedside neuromonitoring markers. And dynamic monitoring during ICP spike showed that both modalities responded to therapy. But greater improvement in EDB, PI and ICP-TCD was associated with survival, suggesting the recovery of cerebral perfusion is a key determinant of outcome.
Very good
Thank you.
data. Very difficult work. A lot of analysis can still be added into this. You have the tracings, I guess, of all the
Yes, sir.
patients. I think the intra-observer variability you can calculate yourself. And also ONSD variability should also be, somebody should independently see, because you can't be there all 24 hours for all 90 patients. So just get it. So next time somebody does, it is very clear and correct. And also the effect of plasma exchange or CRRT or anything, you should add the variables. So, but it's a good work. Rakhi, any comments on this?
CRRT is very important.
Yes,
Yeah, so we should see the effect, the speed, how much that can be. Any other comments?
How did you put the probe? Where did you did
I
that?
realize the pediatric department is pediatric department. They love each other so much.
We take so many lessons from here, so that's why we ask so many questions also.
Sir, I wanted to say only one line. Inter-observer variations can be reduced because in ICU setting, a lot of inter-observer variations can be reduced. Like we have measured ONSD, we have to compare it with the globe size and also the site where we have measured this diameter. So that is also very important because I can measure somebody else will measure at different site. And second is the intracranial Doppler parameters like peak systolic velocity and diastolic velocity. We all know that it increases and then reduces in the diastolic phase, and the RI and PI are calculated. But there are studies in which these inter-observer variations can be reduced by taking multiple sites, multiple windows, and compare, and then mean values can. It is just a suggestion.
That we already know now. We took a-
I have not seen the ICU setting, so
How